Cervical spinal surgery aims to treat pathologies that affect the spinal cord or the nerve roots in the neck. The surgery is done through either an anterior approach, i.e. an approach from the front part of the neck, or through a posterior approach, i.e. an access through the back of the neck. Each of those has its own advantages and disadvantages, and is usually utilized depending on the underlying pathology being treated. Cervical spinal surgery, access to the neck is very important, and securing that through an anterior approach utilizes a very elegant path between the soft tissues of the front of the neck, which means that the dissection or the exposure requires very little in the way of disruption of the soft tissues, but merely aims to push the tissues one way or the other to create an access. The posterior approach is slightly more invasive because it requires the detachment of the muscles off the bones at the back of the neck. Both approaches serve a purpose that aims to treat a pathology or a problem that can be best identified on investigations. But generally speaking, once the spine is approached, the main aim is to relieve any pressure that is applied on the nerves from the underlying pathology and provide stability to the spine at the same time. To do this, the discs can be emptied and the spinal cord or the nerves visualized before a specific replacement, pre-planned and agreed, can be utilized, either through a fusion cage or through a disc replacement. The posterior spinal surgery is predominantly aimed at providing a wide cross-sectional area for the spinal cord to allow it to recover and heal. But there are certain situations where it also can be utilized to take the pressure of isolated nerve roots if required. Generally speaking, recovery from cervical spinal surgery is quick. Most of the patients end up staying in the hospital overnight, going home the following day, but some can stay for an extra night or so. With anterior surgery, and because the soft tissue disruption is minimal, it is expected that the amount of pain post-surgery is minimal. Having said this, some patients can sometimes experience difficulty swallowing, which is something that is not severe and usually resolves over the course of the next few days. And some others can experience hoarseness of the voice because of a stretch of one of the nerves that goes to the voice box. That, again, for the vast majority of the patients is temporary and settles down within the few weeks after the surgery. Posterior surgery tends to be slightly more painful, but nothing that would stop patients from going back to as normal activity as they did prior to the surgery with regards to the pain. And the expectation is that the pain will settle down substantially over the course of the few days following the surgical intervention. Generally speaking, patients will not notice a significant reduction in their neck range of motion following spinal surgery on their neck. With this in mind, the surgery is sometimes associated with a fusion component that will marginally reduce the segmental range of motion for part of the neck. We do, however, now have technologies that not only help to restore the height of the affected disc, but also simulate the normal natural movement of the spinal column, protecting the adjacent segments from significant degeneration expected if part of the spine is fused. The gold standard for spinal surgery has been for many years now the use or utilization of a fusion device after the discs causing the problem are managed or treated. With this in mind, the technology has been progressing quite substantially in the field of motion preservation. And there is now good implants that aim to simulate normal disc motion. The evidence for those have become more recently in the public domain, supporting them to be not just as good as fusion procedures, but also better from patient-reported outcome measures too for certain implants. And not only are they good in preserving motion, but they also, because they preserve motion, they also help reduce the stress or the strain on adjacent non-operated segments in the neck, and therefore reduce the risk of symptomatic adjacent segment degeneration, which would have normally been a risk of 3% per year, or in a broader term, 1 in 3 of the patients would suffer it over the course of 10 years following their initial fusion surgery, if fusion was chosen. Generally speaking, the pros and cons of motion preservation are very similar to those of fusion, in the sense that we are introducing a replacement device to replace a diseased disc. With this in mind, on occasion, that replacement device might not function as planned. And if that is the case, then the patient would, despite having a joint replacement or a disc replacement, end up with a fused segment, and their risks for adjacent segment degeneration becomes just as high as the ones that have had a fusion. There are some components of some implants used to replace discs that can also wear and tear over time, and that can in its own right cause issues. However, the chances of that happening is very small, and for the most part, I would say that the most important disappointment that can sometimes be noted with motion preservation is inadvertent fusion of that segment because of the overgrowth of bone around what is supposed to be a mobile component.